All right, I think we'll go ahead and get started. We do still have some additional people joining. So if we hear a few beeps at the beginning, just as they are joining the meeting, I wanted to welcome everyone. This is our second of two panel presentations titled Long COVID, Not Crazy or Lazy, Exploring Impacts on the Patient and Community. This is a Clarkson College Leadership Series event presented in collaboration with the University of Nebraska College of Public Health. Just get my slides to progress here. All right, we are so happy to join us, all of you this evening. I know we have participants actually from all across the country and even different countries in Europe as well. So welcome, welcome to Nebraska from a virtual setting. My name is Sarah Flanagan. I'm the Director of Community Health and Interprofessional Education here at Clarkson College. I will be your moderator for this evening's panel presentation. Before we begin, I do want to ask everyone, if you've signed in, would you please make sure that you update it to actually include your first name and your last name so that we can match that with our registration information. As we begin then, I would like to share with you just briefly the genesis of this idea. As we all experienced firsthand the COVID-19 pandemic evolving and unrolling before our eyes, it became apparent very quickly that there were a lot of things for us to learn and a lot of new unknowns. As more people began to experience lingering effects of the virus, we also realized that we were entering into new uncharted territory. There hasn't been a lot of information on long COVID until just recently, and what is there has tended to be either very clinical in nature or more of the individual human interest stories covered by local media. Sharon Eden, a microbiologist and epidemiologist who teaches in our community health and general education programs here at the college, approached me to see if there was something that we at Clarkson College could do to help address this growing need. We wanted to be part of the solution, not that we could go and conduct all these fancy research studies or produce new treatments, but rather, how could we be a vehicle for sharing information, and how could we work to bring people together so they didn't feel so alone or misunderstood in their experience. We wanted to bring a human touch to this evolving situation and to help increase awareness and empathy related to the experiences of those living with COVID symptoms. In response, we brought together a wonderful team of dedicated professionals to help create these two panel presentations. We already had our Clarkson College Leadership Series as a platform through which we could reach out to people across the country. We also have an amazing team of faculty in our community health department who have already been integrating information on COVID and long COVID into their courses for students, so we involved them as well. As mentioned, we really wanted to create an experience that helps bring people together, to help them feel informed, connected, and empowered so they could help themselves, their families, and their surrounding community. And as you all know, in light of social distancing, we determined that Zoom would be the best way to deliver this message. And so here we are. Thank you all of us again for joining us tonight and being part of this conversation and circle of support. So without further ado, I would like to introduce you to each of our panel presentations or panel presenters. First, we'll begin with Dr. James Lawler. He's Executive Co-Director of the Global Center for Health Security and the Deputy Medical Director of the Nebraska Biocontainment Unit. Before joining the University of Nebraska Medical Center team in November 2017, he served 21 years in the U.S. Navy Medical Corps. Dr. Lawler is an infectious disease physician trained in tropical medicine and public health, whose career has focused on research and policy related to emerging infectious diseases, pandemic threats, and health system and public health preparedness. He'll start us off with an overview of what long COVID is and what we need to understand about it. Next, we'll hear from Dr. Caitlin Hebrew, a licensed physical therapist and assistant professor in our Physical Therapist Assistant program here at Clarkson College. She has spent much of her clinical career in the home health setting, where she continues to work on a part-time basis. Dr. Hebrew will be sharing her insights and experiences working with long COVID patients from a functional rehabilitation perspective, trying to help support people as they recover from these lingering effects. We're blessed to have Bonnie Dolan as well. Bonnie is a nurse at Nebraska Medicine, where she's worked for more than 30 years. She'll be sharing her experience tonight as someone who's living with long COVID. We appreciate Bonnie's optimistic outlook and her willingness to share her personal journey as she brings a firsthand account to this misunderstood condition. Finally, we'll round things out with Maureen O'Donnell, counselor and owner of Arbor Family Counseling. Maureen will talk about the impact of long COVID on one's mental and emotional health, as well as some tools and coping strategies to help patients, families, as well as providers. I want to thank all of our panelists for the hard work and time they put to put this presentation together this evening, and for also taking this opportunity to be here with all of us. As a quick reminder to our audience, do please write in questions into the chat function. We will hold on to them until the end, at which point, when we get to a question and answer portion, all of our panelists will be able to come off mute and share their video and take that opportunity to answer the questions that you may have asked. And without any further ado, Dr. Lawler, the floor is yours.
Thank you so much, Sarah, and it's great to be here with everyone this evening, even if we're not together in person. So if we can move on to the slide deck here. So thanks again, and it's great to be able to talk to folks about long COVID, which is, as we mentioned, something that is a new diagnosis and something that we as medical professionals are learning about on a daily basis. The long COVID or long haul syndrome or post-COVID-19 syndrome has many different names that people have used. I don't know that we've quite come to a consensus of what the appropriate term is for this syndrome, but persistent post-COVID syndrome seems to be a good name from my perspective, since it somewhat captures the gist of what we're talking about. And even how we define this syndrome, let alone the name, is somewhat still arbitrary and up in the air. I think in general, it's helpful to think about it as a set of symptoms or potentially new onset of symptoms that occur at some point remote from the acute infection of COVID-19. Arbitrarily, 3 to 4 weeks have been the most common timelines that people have used. And that is in the absence of ongoing active SARS-CoV-2 infection. This is potentially somewhat overlapping with another syndrome that has been widely recognized and I think talked about, which is the multisystem inflammatory syndrome. Initially, this was recognized as a disease exclusively of children after COVID infection. But since that was brought to light really over the summer, this has become more commonly recognized to also involve adults. So these two syndromes are called MIS-C and MIS-A to differentiate between children and adults. But while these two entities are overlapping, really when I think of the persistent post-COVID syndrome, I think of something relatively distinct. So just to kind of dig into a little bit about MIS-C and MIS-A, because I think they're important things to know about at least. These are hyperinflammatory syndromes which tend to occur soon after COVID-19 infection. Again, was initially described in children and really more closely resembles a syndrome that we see not infrequently in children called Kawasaki disease. And this inflammatory syndrome is generally characterized by fever and high inflammatory markers, and then multi-organ damage, commonly involving the heart. And certainly that's one of the hallmarks of Kawasaki disease. But the important thing to note, as both in kids and adults, this is really an acute inflammatory and severe illness that can be life-threatening. And while the other manifestations of post-COVID syndrome certainly can have multi-organ system manifestations and elements of inflammation, it is not the same acute severe illness that multisystem inflammatory syndrome is. So there are multiple ways to get to post-COVID syndromes. The acute manifestations of COVID really range all over the map for these folks who end up with some type of long haul syndrome. It's been described certainly more commonly in people who've had severe episodes of COVID-19 that require hospitalization. But manifestations of persistent post-COVID syndrome or long-haul COVID have been described even in people who have very mild or asymptomatic infections. And again, these can also manifest as the multisystem inflammatory syndrome. So almost any type of acute infection from COVID-19 can eventually wind up with these persistent symptoms. Again, the definitions vary. You can see in this figure, in this paper by Amenta, they describe the syndrome as occurring after 3 weeks, but 4 weeks is also a very reasonable way to characterize the illness, and some have even gone longer. Important to note that while we had previously thought of COVID-19 as an acute infection that was really primarily located in the respiratory tract, we've learned since that acute COVID-19 can affect really all organ systems. And this probably is important in how we think about and frame discussions in persistent post-COVID disorders, because it is probably true that this acute infection involving multiple and remote organ systems from the respiratory tract probably is important in the pathogenesis or the mechanism for developing long-standing symptoms and injury that may be manifested in this persistent post-COVID syndrome. So in addition to the mucosal linings of the respiratory tract that includes the lungs, we have recognized more and more now that COVID is really a disease of the blood vessels and the endothelium, or the lining on the inside of the blood vessels. And that's why if you've paid attention to some of the reports about COVID and read some of the literature, more and more cases of different types of clotting disorders, blood clots, either in large vessels and small vessels, have been demonstrated in COVID patients. And so obviously the blood supply and blood vessels are present in every organ system, and therefore even just a virus and inflammatory response that affects the small blood vessels can affect just about every organ. And this organ damage and organ impact appears to come in several different forms, one of which is potentially direct viral infection and damage of tissues. So the SARS-CoV-2 virus can invade multiple different types of cells because it attaches to the ACE2 receptor on the outside of cells, and that receptor is actually expressed by a wide variety of organs and cells within the body, not just the lining of the respiratory tract or the lining of blood vessels. And so that direct infection and direct viral toxicity is one mechanism by which COVID affects these organs. But also the virus manages to elicit a very robust immune response, and all of the inflammatory mediators and evil humors, so to speak, that are involved in a hyperinflammatory response can also lead to end organ damage, and are certainly things that affect people in acute COVID disease. And so all of these different pathways potentially have long-lasting impacts that can run into this persistent post-COVID syndrome. So this is another kind of timeline representation of the disease and when we see these different manifestations. Again, during acute disease and even before, you have viral replication and the presence of viral shedding, mostly from the respiratory tract. But again, the shedding can occur from other organs as well, including the gastrointestinal tract, which again just demonstrates the fact that the virus has tropism and can go to lots of different organ systems. You get a peak in viral shedding, both from the nasopharyngeal mucosa and other tissues, And then that generally begins to wane as the disease progresses, and usually goes away by the third or fourth week in terms of our ability to detect the virus. And that is generally when we see acute manifestations of COVID-19 subside, and then we have the post-acute or longer standing long haul symptoms, again, that you can see involve potentially many different organ systems. So a number of, or a wide constellation of symptoms have been noted in persistent post-COVID or long haul symptoms or long haul COVID syndrome. Most commonly, people report fatigue, and this fatigue can be quite extreme. People often complain of shortness of breath or decreased exercise tolerance. Chest pains, sometimes relatively significant, are frequently reported, and it's unclear whether these chest pains are actually musculoskeletal or anatomic from the chest wall, or whether they involve the heart or the lungs. They are often difficult to characterize, but people certainly can have persistent cough, headache, and other neurological symptoms such as sleep disturbance, anxiety and depression, and memory loss, or just brain fog and general cognitive dysfunction are frequently reported. People are increasingly noticing this disruption of the autonomic nervous system, or dysautonomia, which can often result in things such as postural hypotension. So people standing up from a seated position can get lightheaded and even have syncopal episodes because the autonomic nervous system is unable to compensate as it normally would. Other things that are reported are people who have persistent loss of taste or smell, which is obviously usually an acute manifestation of COVID. And then the behavioral health and mental health issues like anxiety, depression, and post-traumatic stress disorder, particularly for people who've spent a long period of time in the hospital, are commonly reported as parts of this long COVID syndrome. Other symptoms, and indeed other signs, physical manifestations that can be measured, are often seen in some of these patients. So many have diminished pulmonary function tests. Their lung capacity and other functions that are measured in PFTs are often abnormal and can be for 6 months or more. When researchers have performed echocardiograms or MRIs on post-COVID patients, they have found that many have evidence of inflammation of the heart muscle or impaired cardiac function. Again, most of this resolves on its own. Many patients have acute kidney injuries during their COVID episode that can persist, but some seem to develop some form of chronic renal injury. Some people experienced hair loss, some people experienced skin conditions. Patients with underlying endocrinologic disorders such as diabetes often will have their disorders manifest as more severe, or in the example of diabetes, they can have difficulty in controlling their blood sugars. People with thyroid abnormalities can see those worsened. We've seen a pretty broad range of different manifestations. Risk factors for the development of long COVID are not well understood. In general, there does appear to be a correlation with severity of disease, so that people who've had more severe bouts of acute COVID, who've been in the hospital or intensive care unit, tend to have more severe disease. We have also seen more cases of long COVID potentially in minority communities and communities with health disparities. And this probably relates to the fact that these communities also had generally more severe disease, and that may be because of some underlying chronic medical conditions that communities with poor access to care generally have less control of these chronic diseases and more significant organ damage. The long COVID syndrome has been described somewhat more commonly in members of the female sex versus males, and we think that there are probably others that have yet to be well characterized in terms of risk factors. I think it's helpful to look at this in the context of what we've seen with other post-infectious or post-illness syndromes, and to understand that this is not necessarily new and certainly not confined to COVID-19. I think every infectious disease physician certainly has seen patients with some sort of manifestation that looks like what's classically described as chronic fatigue syndrome that occurs after viral illnesses, and these patients can often have symptoms that last for 6 to 12 months. There also was reported a very high incidence of this type of syndrome following infection with SARS and MERS, the two other kind of novel beta coronaviruses that cause severe disease that emerged over the last 20 years. Indeed, patients who have severe sepsis of any flavor and require ICU hospitalization often end up with a prolonged period of recovery that have many of the same types of symptoms manifest, and can have evidence of significant organ dysfunction afterwards. One of the common features that seems to be very closely tied together is the manifestation of post-traumatic stress disorder, which occurs also in these post-sepsis patients. And that seems to be really more related to the experience of being in the ICU with a very severe illness, rather than something that's specifically related to the SARS-CoV-2 virus. And then interestingly, if you go back into the history books and medical reports, you read all sorts of descriptions of these types of symptoms that occurred in patients convalescing from the pandemic flu of 1889, which is called the Russian flu, the pandemic flu of 1918, which was called the Spanish flu. And you have all sorts of creative names that were discussed at the time, including things such as nerve exhaustion, neurasthenia, grip catalepsy, inertia. I actually have no idea what inertia is, but apparently people developed that after these flus, encephalitis lethargica, and many other names. Treatment of long-haul COVID syndrome still, unfortunately, is really supportive and symptomatic. There yet are definitive therapeutics that we can give to make these symptoms go away. Oftentimes, it involves appropriate management involves a multidisciplinary team that can address all of the different symptoms that an individual patient is experiencing. Again, all of these patients are somewhat different. Very few have exactly the same constellation of symptoms, and so this multidisciplinary approach is really important. And really, it's more of a rehabilitative process that involves good nutrition, exercise, mental health interventions, and counseling. Other therapies potentially can be helpful, even occupational therapy and physical therapy. But the important thing to note is the vast majority of these people get better. Most symptoms resolve within 6 months. Some patients have had symptoms that have gone out beyond the 6-month mark. Obviously, we're now 15 or 16 months into the pandemic. So certainly patients from Wuhan and early in the epidemic in China have been reported to have persistent symptoms, but they generally wane over time, and these conservative interventions appear to provide significant benefit for folks. Because of that idea of these patients needing, in some cases, intensive multidisciplinary management, these clinics for long-haul COVID have popped up all over the country, and certainly we here in Omaha have started to develop these clinics to help manage some of these patients. Nebraska Medicine has a clinic that has stood up recently that still, until the end of this month, is right now only focusing on UNMC employees and family members, but soon will open up to all of our Nebraska Medicine patients. And then the plan is, last I heard, in July to be able to open up for the general public for appointments. It's a multidisciplinary clinic for adults with symptoms that persist 8 weeks post-infection. Children's also has a clinic that is focused on pediatrics, obviously. And then I have heard that other centers around Omaha, including Madonna and CHI, are also either in the process of or have opened long COVID or post-COVID syndrome clinics as well. So this will be an important step forward for folks who are experiencing these symptoms, and hopefully will help them to start on their journey to wellness. But again, it is a long process. So with that, I'll thank you and turn it back over to you, Sarah.
Thank you, James. I appreciate it. We really appreciate that insightful overview because it's helpful, I think, for all of us to really look at what's happening in all those different parts of the body, all the different organ systems that you touched on, and how the COVID virus can impact patients not only in that acute time period, but then obviously with those lingering effects as well. So that was really helpful to get a breakdown and to see at the end there what resources we have available and what more will be coming here in the future. So thank you for that. Next, we're going to have Caitlin Hebrew, and she will be talking with us about kind of that physical therapy side, the functional rehabilitation piece, and the importance of really being in tune with what patients are sharing with you and what are some steps we can take to help them make progress and improvements. So it is your turn, Caitlin. Thank you.
Sure. Okay. So I am Caitlin Hebrew. As Sarah mentioned, I'm a physical therapist, and I work primarily in the home health setting, typically with a geriatric patient caseload, but I do have experience over multiple fields. So I want to just talk to you guys a little bit about what the rehab perspective looks like for patients with long COVID. Prior to even discussing the effects of COVID in terms of a functional standpoint over an extended period of time, I wanted to just discuss a bit about like the physiological effects of immobility. So Dr. Lawler just shared an amazing infographic about the effect of the actual COVID virus on the systems of the human body. But we also know that immobility has significant effects on all of our physiological systems that I've described here on this slide. The amazing thing about the human body is that it is able to specifically adapt to its imposed demands, which is great. If we don't use it, we lose it. So with immobility, the demands on the human body and the systems have greatly decreased. COVID, as Dr. Lawler mentioned, is a systemic disease. It's not just a respiratory deficiency. It's not the common cold. We're seeing patients who have been immobilized for an extended period of time due to the acuity of their illness, presenting not only with the effects on the physiological system of the virus itself, but also the effects of immobility. So as the slide shows you, we see the effects such as osteoporosis, muscle atrophy, and weakness. In the musculoskeletal system, the neurological system, we see things as depression, anxiety, forgetfulness, and confusion. Adding into that, the brain fog that we're seeing with the COVID virus itself. With the cardiovascular system, obviously, we are having issues with blood pressure, cardiac muscle atrophy, clots, and cerebral vascular accidents that are pretty common here with some of our long haul COVID or even in the acute COVID patients that we see. Respiratory system, of course, being affected by this COVID virus, the gastrointestinal system, long-term effects of immobility, laying in bed for an extended period of time, just not completing your normal daily activities, can have effects on the gastrointestinal system, the genitourinary system, the integumentary system, and then, of course, the metabolic system. So I put on the slide that COVID is being kind of considered as a diabetes on steroids. And I'm going to talk about that a little bit more here on the next slide. But the diabetes on steroids is a good descriptor, in my opinion, of what COVID is looking like in terms of a long-term functional assessment for a patient. We all know what long-term implications diabetes has on the systems of the body. COVID is speeding up and accelerating an inflammatory systemic response that we're seeing on all systems of the body. So the question, of course, if you ask a therapy or a physical therapist, occupational therapist, speech therapist, is to move or not to move. So the COVID patient, of course, in the acuity of the diagnosis is very ill. So should we allow them to rest and heal? And the answer to that question has to do with assessment of the acuity of the patient. It's a benefit versus risk assessment that really involves, collaboration between an interdisciplinary team. In my opinion, as a physical therapist, and I think most medical professionals would agree, that movement is truly the key. But again, assessing the acuity of that patient is important in protecting our patients from additional complications of the diagnosis versus weighing out the benefits of getting them up and moving. Maybe it is that the patient has a change in symptoms that have occurred over the last 20 to 30 minutes. As we know, COVID is constantly evolving and changing its presentation from individual to individual. Maybe the therapy team or the rehab team has an idea for movement that wouldn't have been typically thought of by a team caring for someone in a very acute or intensive care intensive care setting. So significant amount of research indicates that early mobilization improves our functional outcomes in our patients who have been immobilized for any length of time. This has kind of shifted a bit in recent years with the treatment paradigm. It used to be if you were very ill, you were prescribed bed rest. That's not the case anymore. We know that with the COVID diagnosis, as Dr. Lawler mentioned, we're seeing this significant inflammatory disease, an inflammatory response called the cytokine storm. Well, we also know that with inflammatory diseases and systemic issues, that regular exercise is a fantastic intervention for preventing further complications of those systemic diseases and alleviating signs and symptoms of those systemic diseases. I put on the slide the effect of early mobilization on the incidence of long COVID, and I wish I had some great data to share with you guys in regards to how important it is to get these patients up and moving, but it's just too soon for us to find out whether early mobilization significantly decreases a patient's risk for moving into kind of the long haul COVID system. Okay, so in terms of a rehab timeline for a patient with COVID, typically if a patient is ill enough to be hospitalized, then therapy is going to start right away in that acute care setting. In the acute care setting, our functional goals are always to get out of the acute care setting. So the discharge from the hospital is going to be the functional goal for the rehab team here. We're really focusing on avoiding post-intensive care syndrome, ICU acquired weakness. Again, these are kind of sequelae from the COVID diagnosis that we're seeing that go along with a patient being immobilized for an extensive period of time. Post-intensive care syndrome and ICU acquired weakness are not only seen with COVID patients. They're seen with any individual that's been in an intensive setting for an extended period of time. So early mobilization is very essential with the utilization, of course, of a risk assessment algorithm. So the algorithm that I'm familiar with and that I think is just fantastic is the MD Anderson Center ICU Adult Early Mobilization Algorithm. And it's something that is multidisciplinary. So all sorts of healthcare professionals can utilize this for a team approach in determining whether a patient is healthy enough, essentially, to get up and move around. In the acute care setting, that's our goal: movement, discharge from the hospital. Following a hospitalization for a patient who was ill enough to be hospitalized, the patient typically goes to a subacute care setting where our functional goal then switches to returning home. So what does it look like for us as a rehab team in order to safely recommend that a patient can return home? And those things have to do with their medical stability. Are they able to leave supervised care? Are they able to be in their home stable medically without intervention of different healthcare professionals? That's primary. The second, of course, would be returning home to a safe environment with the appropriate level of support. This requires home assessment for us as a rehab team, establishing support systems, establishing any kind of transitional care, and then, of course, medical equipment that these patients might need once they return home. Moving into the chronic care setting, our functional goals as a rehab team transition into returning the patient to normal life. Now, I will make a small note here that we are seeing a large number of patients who transition home versus a subacute setting. And this is due to multiple different factors that occur kind of in our healthcare world right now. A lot of subacute care settings are seen as congregate living environments, and we know the effect of a COVID spread in a small environment. Family access is a huge thing. If families are not able to come in and see their loved ones in a subacute setting, often these families are choosing to take their loved one home. And then, of course, with everything in our healthcare system here, reimbursement issues might also be something that's limiting an otherwise healthy patient from transitioning into a subacute care setting. It is expensive, especially after a certain period of time and depending on the patient's coding, diagnoses, comorbidities. In the chronic care setting is where we're kind of seeing this emergence of the long COVID patient. And in the chronic care setting, we also might see or be introduced to a patient who has had COVID that was not ill enough to be hospitalized, but is now presenting with these long COVID signs and symptoms. So in terms of the long COVID patient, does age really matter? Dr. Lawler mentioned some different predisposing risk factors that seem to be trending in order to diagnose a patient with a long COVID. But in terms of a rehab perspective, does age really matter, and how does this affect their rehab plan? So we take into consideration things like the severity of their long-term effects. If I am of an older age, a severity of me being hypoxic for an extended period of time has significantly more functional and medical implications than if I'm slightly younger. Our patients who are older typically have more comorbidities. What do those kind of things look like with all of the different sequelae that are presenting with the COVID diagnosis? As you age, unfortunately, the rate of healing for your body systems decreases, just one of the joys of aging. We also take into account what is the prior level of function. Generally, our younger patients exist at a higher level of function than our older patients do. So we're tailoring our rehab plans to meet the patients where they are at and to meet the patients where they'd like to go. Caregiver support is another large consideration in terms of age and the long COVID patient. With older patients, occasionally they'll already have caregiver support set up. Maybe our younger patients don't have a established care or a great support system for things that they might need. And then I've been seeing some interesting data about vaccination and the effect of a vaccination on decreasing the signs and symptoms of long COVID with patients who had previously been diagnosed. I wish I also had some better statistical data for you, but some studies are saying that vaccination can aid with the long COVID side effects. It's just a little too soon to tell. Okay, so functional long-term implications for our long COVID patients. This is so much more than a simple virus. So as Dr. Lawler mentioned, there are multiple different acronyms that we're using to describe patients who are presenting with these symptoms. I see typically in my practice post-acute sequelae of SARS-CoV-2 or PASC. These patients are presenting with all of the signs and symptoms of long COVID, brain fog, pins and needles, exhaustion, elevated heart rate, all of these things that make it very uncomfortable for these patients to participate with rehab. How would you feel exercising under these same conditions? In terms of our function and how close we can get our patients to their prior level, we have to determine what their prior level is and how we can get them back to living their life. With our patient-specific plans of care that we're establishing, every patient is individualized. We are considering their age and activity level prior. We're also highly taking into account the mental health. This is a life-changing infection for a lot of our patients. It essentially adds a systemic disease process to our patients who are presenting with these long COVID signs and symptoms. That's pretty tough thing to deal with if you're a patient who was previously healthy, especially in our younger population. I did on this slide include this infographic from the National Institute of Mental Health, which I just think is so interesting because we're talking so much about COVID-19 and also the mental health implications that go with that. We're seeing so many complications and so many complaints of our patients reporting these different mental health symptoms that we made up the National Institute of Mental Health felt that it was pertinent to establish an infographic explaining the two. You'll see in the middle here, there's overlapping symptoms: chills, shaking, sweating, chest pain, hot flashes, shortness of breath. As a rehab professional, we're constantly assessing all of these things and providing significant levels of encouragement and positive reinforcement for these patients whose life has essentially been changed by this diagnosis. In terms of our rehab role in the long COVID patient, as I mentioned on the previous slide, we are constantly going under assessment or assessing these patients. Due to the nature of the profession and the physiological system's response to healing and the principles of healing, one of the great things about my job is that I get to establish relationships with patients and work with them over an extended period of time. As you guys are all aware, you can't go to the gym one day and do some bicep curls and have bigger biceps. It does take some time, but this often means that the rehab professionals are the only healthcare workers frequently laying eyes on the patient. It's very important for us to monitor their signs and symptoms and to ever change and evolve their plan of care based on meeting them where they're at that time. This slide is definitely physical therapy focused, as I'm a physical therapist. We do things such as strengthening, endurance, balance training, working on independence with mobility, cardiopulmonary rehab, and the psychosocial role, of course. But I do want to make a quick plug for my fellow rehab professionals, occupational therapy and speech therapy, who also have crucial roles in the rehabilitation process for the long COVID patient. Speech therapy can work with mental health issues, brain fog, memory issues, if there were swallowing or respiratory issues prior to the COVID infection, and we're seeing some complications there. It's absolutely essential that we get speech therapy involved. Occupational therapists, I consider a jack of all trades, working on getting those patients back to being as independent as possible with their activities of daily living, integrating patients back into their community environments, all very, very important OT roles here. With the cardiopulmonary rehab, for a therapy perspective, we're seeing the paving or the marbling of the lung tissue, which presents differently than a typical cardiovascular or cardiorespiratory patient for us. With the psychosocial role, some of these patients are overcoming near-death experiences. They feel isolated. They feel that there might be a stigma attached to them. They feel that they might have an inability to ever return to their normal life. There's an unknown in regards to what the true prognosis of long COVID looks like for these patients. We like answers and we like them now. And this is one of those things that we just have a really hard time giving clear and statistically backed evidence to our patients. So just constantly working on maintaining positivity and working up that rehab ladder back to their prior level of function. Some different barriers that I'm finding, especially in the care of the long COVID patient, can be listed here. And some of these are COVID specific, and some are just healthcare barriers to care in general. So obtaining the diagnosis of long COVID, everything in our healthcare system is code-based, right? So ICD-10 codes. Underprivileged populations typically have difficulty obtaining diagnoses. Young COVID, long COVID sufferers typically have a difficulty obtaining a long COVID diagnosis. If they weren't ill enough to be hospitalized, it's hard to convince a younger person who's maybe feeling these long COVID symptoms to contact their primary care physician and obtain a diagnosis. We're seeing some barriers with the accessibility to the correct level of care. So as I mentioned before, are these patients coming home because they don't prefer or because their families have chosen not to send them to a subacute setting? Is that the true setting for them to be in? I see a significant amount of home patients who are requiring the level of care that is provided in a subacute setting, but aren't receiving it in the subacute setting. So our entire kind of treatment model with rehab has shifted a little bit in the home health setting. Are they utilizing services? This is a big one for the younger long COVID patients. Are they aware that they have long COVID? Are they aware of the services that they can utilize to improve their outcomes? Do they realize that just because they weren't hospitalized with an acute, life-threatening COVID infection, that does not mean that they're not able to receive care for this long COVID diagnoses. And I have a big push for here at the end about getting therapy referrals for all patients who are suffering from long COVID. Of course, nationally, we're seeing, healthcare worker and equipment shortages. This is improving as the kind of wave of COVID, acute COVID, has tailed down a little bit at the end. Are there enough healthcare workers to provide adequate care in the patient's current setting? Do we have equipment shortages still? Is there enough PPE that is necessary to provide safe and effective care? Are these patients able to access medical equipment like portable oxygen, assisted devices, any other medical equipment that a patient might need to be as independent as possible in their own living environment? With our older individuals, we're seeing Medicare reimbursement issues. There's been some policy changes that were enacted in January of 2020 that has had a significant effect on the amount and type of reimbursable services, especially if a long COVID diagnosis has not been obtained. Moving into caregiver support. Is the caregiver support for our long COVID patients available? Is it sufficient? This is tough with younger adults. Some of these younger adults might be caregivers themselves. Some of these younger long COVID adults might be caring for a parent with long COVID. Occupational and social support with our younger patients. Can the patient safely return to work? If not, are they able to financially support their lifestyle? Are they able to receive benefits through an employer that could pay for their rehab services? And then with all medical diagnoses, accessibility is often a barrier to optimal care. So insurance coverage, transportation to and from medical appointments, financial resources for healthy food options, financial resources for levels of assistance, safe environments for exercise, and then health literacy and education. Are our patients able to understand the education that we're providing them? Are they able to access the necessary information to achieve their best outcomes? And then just in my own personal opinion and experiences, I will say that my primary complaint for my long COVID patients depends on their age and activity level. So older adults, our geriatric population, typically complain of an inability to function at a much lower level. We're seeing shortness of breath at rest, which is very anxiety inducing. And then fatigue, which hinders their basic mobility levels. So if I'm an older individual, if I am so fatigued that I am unable to get up and go to the bathroom, that's a significant issue in my quality of life. Getting dressed is fatiguing enough for someone who is suffering from long COVID signs and symptoms. With the younger adults, typically I'm seeing complaints of inability for them to complete their occupational and recreational tasks. They're not able to return to work at their optimal performance. They're not able to engage socially in the way that they previously were. They're not able to participate in their recreational activities in the way that they previously were. Big complaint for the younger adults. A lot of my younger patients say, I used to run 5Ks. Now I can barely make it up the stairs to my second floor. So lots of different feelings of hopelessness, depression, isolation for all of my long COVID patients that I'm seeing. And I just want to strongly put a push here to consider a therapy referral for a patient with long COVID. We are out in the field working with these patients over an extended period of time. We are ready and willing to continue to provide care to return our patients to the highest level of life and function in which they can achieve. And that is it for me.
Thank you, Caitlin. We really appreciate you giving all of us that better understanding of how the body is impacted by long COVID, but then really from that, even more so, the different challenges, right? Those barriers that patients might face, that providers face. That was interesting as you talked about, even in terms of how conditions are diagnosed and then coded and how that impacts reimbursement. And then the whole kind of litany that follows from there in terms of what support services patients are able to access or not. So you raised a lot of really important points for us to consider, and we appreciate your time. Next, we're going to switch to Bonnie. Bonnie is going to share about her own experience as someone who has lived with long COVID. And so, Bonnie, we are anxious to hear from you. Thank you.
Hey, everyone. I am Bonnie Dolan. I am a nurse and a COVID crusher, as I call it. Let's see if I can get this to flip to the next screen. There we go. I've been a nurse here at Nebraska Medicine for over 30 years. I started at Clarkson. I have been mostly a cardiovascular nurse, but have recently joined the psychiatry department. I'm a wife to my husband of almost 28 years. I'm a mom to 4 children. 3 are triplets that are going to be 27 in October. And then an older one that's going to be 26 or 7. I always get them mixed up. I only have 2 birthdays to remember. Plus, it's my post-COVID. I believe in that on it. I'm a pastor specifically to the intellectually impaired. And I love the outdoors and to advocate for those in need. My story started actually before October 21st. Because I am in psychiatry, we offer here at Nebraska Medicine and UNMC what's called a PINS program. So what that does is it takes a employee of Nebraska Medicine that is having trouble dealing with or coping with COVID patient issues, or just issues of their own. They're feeling overwhelmed. They can't handle one more patient dying. So they get assigned to one of us in psychiatry. So I have been a PINS partner for several Nebraska Medicine employees prior to my lovely induction into COVID on October 21st. I had been significantly diligent about wearing a mask, not going out in public. I was one of the first employees to work from home, but it didn't make any difference. It still got me. I woke up during the night, my whole body was shaking. The bed was shaking. I had a severe headache, and I've had migraines in the past. This was worse, and it was really odd. More on the top of my head, severe nausea, chills, and I had a really deep, loose cough. I was tested through Test Iowa for COVID on the 22nd. On October 23rd, which was my triplet's birthday, I tested positive for COVID-19. I was scared, shocked. I really, really hoped. I had prayed, please God, just let it be anything else. I promise I'll do this better. I'll do this better. But it wasn't meant to be. I notified all my doctors because I do have a history of asthma. I have adrenal insufficiency, and I also have pre-multiple myeloma. So I notified all my physicians, and they told me what to watch for, told me, to watch my oxygen saturation, my energy level, my temperature, and I hung on for as long as I could. I did not want to go to the hospital. I had counseled staff that had taken care of COVID patients, and it terrified me. I did not want to go. So finally, as my symptoms were getting more severe, my temperature was now consistently over 101. And that was with Tylenol, ibuprofen, going back to back. My whole body felt like I'd been in a dryer, and I was just sitting still. The scariest day of 2020, I gave in on Halloween of all nights to go to Nebraska Medicine emergency room. I could tell that my husband was scared driving me in. I couldn't breathe. By then, I was sleeping 18 to 20 hours a day. He dropped me off at the door because, of course, nobody could come in. I came in, they were ready for me, put me in a COVID ER room, which I have to say, there was a perk to it. I had my own potty, not the fanciest thing, but at least I didn't have to go down the hall. So there were some perks to that. Other than that, I had people coming in and check on me, but it was very limited, nothing like a normal emergency room experience. The X-ray tech that did my X-ray of my lungs was clearly traumatized from seeing all the COVID patients. So I did what I do best, and I listened to him, and I gave him some tips on how to deal with the anxiety and the stress, which in turn made me feel better. My X-ray did come back that I had an abnormal X-ray, so they sent me to CAT scan. That came back that I had what they call COVID glass in both of my lungs. I'll show you a picture of that in a little bit. I also had what's called an elevated D-dimer, which is a clotting factor. And my kidney function from previous lab draws was a little bit elevated, but a few months later, it had gone up a little bit more, and we'll get to that. So they did admit me to the COVID floor. My oxygen levels, I forgot, were also in the 80s. Normal's 90 to 100. Let's see, the COVID floor. Oh my. I've been inpatient before. I mean, I'm no spring chicken. Being in that COVID room was one of the scariest things I've ever had to go through. The people that came in the room, normally, I was used to seeing people with life in their eyes and smiles, and now I couldn't see smiles, and people looked so hopeless and so sad. So that took a big toll on me. I also, from being in the COVID floor unit, you don't get real silverware, you don't get real plates or anything. So everything came in styrofoam, and it just felt so, I don't know the word for it. It just seemed so odd that I was being treated like I had the plague. And then, because of me being a nurse, I also witnessed several drape carts being rolled off the floor. That broke my heart, to know that people are dying without their families. And I was praying I wouldn't be next. Finally got to go home. The hospital made arrangements so that I could have my oxygen at home. This very nice gentleman from Lincare named Dave dropped off my oxygen tank and a circulator before I left the hospital. My husband, family, friends, church family, work family, all took such good care of me. There was always meals being dropped off, or a nice card in the mail, or a surprise from Amazon, which I kind of like. Okay, here's my, and I'm sorry, I couldn't flip these, but my before is on the right. And all of this white in there is the glass. This is my CAT scan from December. I still had some glass in there, and I'm due to have another CAT scan the end of June. After I got home from the hospital, I was still extremely fatigued. I could walk to the bathroom, and that was about it. I would get so short of breath. I was on oxygen 24/7. December 8th, I was finally able to go to my pulmonary appointment. Dr. Poole did a pulmonary function test. It was okay. And I was also able to finally get my flu shot, because I'm also allergic to the preservative in the flu shot. So I have to do it in her office with extra medications. And I forgot to mention too, when I was diagnosed with COVID in October, my endocrinologist had me triple my dose of steroids. So what was said about diabetes and steroids, I was really on steroids and tripled the dose. But I could still sleep 18 to 20 hours a day without any problem. So I got my flu shot. I was happy to get it, which normally I don't like shots. And December 31st, I started a cough again, similar to COVID. I had a low-grade fever. I also was starting to get the weird headache on top of my head. And I was scared that I was getting it again. I was put on antibiotics as a precaution. And then in January, I had a heart monitor test, because I noticed that I would get up and I would be a little lightheaded, which I thought was maybe my blood pressure. But then I would walk around, I would be fine. And then out of the blue, I could feel my heart pounding, and everything would kind of swirl. Now that would happen with movement and sitting still. So I had a heart monitor test done that showed I was having runs of what's called SVT, or supraventricular tach, which is a rapid heart rate. I saw the UNMC cardiologist, Dr. Biddle, on the 21st, and was inducted into the Nebraska Medicine UNMC COVID heart study. number sweet 16. So they took a bunch of blood and they'll be following me for a while. Dr. Biddle was very honest with me and said that we could do an MRI or an echo, but the MRI would probably show something that nobody had ever seen before, and they weren't sure what to do with it. You see, with COVID, they find all these things, but there's no data. There's nothing to tell you what tomorrow is going to be like. It's all a big black hole. Excuse me. On the 26th of January, I followed up with my primary care provider and started to work on a plan for going back to work. I finally went back to work in February. I will say I did a pretty good driving in. I live about 45 minutes away. I got to the parking lot. I thought, hey, Vaughn, you got this. This is going to be good. I turned off the car and I couldn't move. I was having a full-blown anxiety attack. It took a lot for me to open the door of the car and to walk to the elevator and to walk through the hospital. Just being back in the hospital and knowing that I had been there before and things were very unpleasant, were very difficult for me to handle. It did get better. On February 3rd, I did get my first COVID immunization shot and did a major happy dance. I was so excited to get that shot. On February 10th, I had an echocardiogram on my heart. It did show some muscle enlargement, but nothing severe. So Dr. Biddle's just going to watch it, see if any symptoms develop. We'll proceed with an MRI if it's needed. February 24th, I got my second COVID shot, and I'm not kidding. I cried. And it wasn't like I was sad. I was so happy and so grateful. On February 25th, I had my follow-up with my endocrine doctor, who tried to have me come back down on my steroids. I wasn't able to. I was at triple the dose through most of February. March, I was able to drop down to double the dose, but was symptomatic with that. So I had to go back up to triple. Then I got down to my baseline of 5, and now I'm back at double. And that seems to be where I'm going to stay for a while. On March 31st, too, I got to be one of the first people to go to the Nebraska Medicine COVID clinic. The doctor was amazing. He was honest. He was thorough. He did order an MRI of my brain because I do have brain fog. And I also have, during the night mainly, I don't know if you've ever touched on a barbed wire fence when it's been on, but I get barbed wire fence with a bunch of needle pokes at the same time going up and down my legs. But then as soon as that starts, it stops. And then sometimes I just feel like my legs are ice. So he ordered the MRI and diagnosed me with autonomic nerve dysfunction from COVID. The MRI did show a decrease in the size of my frontal lobes. And I will be seeing Dr. Santa Maria on June 21st to get her interpretation of everything. July 6th, I have another PFT, pulmonary lung test. I have another CAT scan of the chest to see if my COVID pneumonia has cleared. I'm praying that it does and we don't have any more unknown surprises. But I have to admit today, every time I get a cough, fever, chills, I just don't feel right. I'm afraid I'm getting more of the COVID unknown. I try to live each day as the fullest and focus on things that bring me joy. I will not stop advocating for long COVID patients and their treatment, for immunizations, or any other unknowns that may come my way. I'm going to end with, never regret a day in your life. Good days give you happiness. Bad days give you experience. Worst days give lessons. And the best days give you memories. Thank you.
Wow, Bonnie, thank you for sharing your story. It's emotional, even to listen to you share, because I can only speak for myself, but I know I'm sitting here imagining all of those different experiences as you described them. And I think that brings such, and I know I told you this before, in kind of anticipating, but it really brings real richness and value to this conversation, because we can get all the clinical information that we can or that we want to get our hands on. But if we don't have that human component, we're missing what it is we're really focusing on. And so I thank you for having the courage to share your experience with us tonight. And I wish you the best in the future with all of your upcoming tests, and hope that things start to turn around really quickly here for you, so you can make a lot of progress and get back to doing the things you love to do. So thank you. Next, we are going to have it's a nice segue here actually at the end here, Bonnie, with the slide that you have. Great way to transition to our last presenter, which is Maureen O'Donnell. And Maureen will be sharing with us, her experiences as a mental health counselor, what she's seeing with patients who have had COVID, even family members, potentially the long COVID pieces that for many people, unfortunately, come after that. And so we'd love to hear from you, Maureen, about your experience and maybe some different tips or coping strategies that you have to share with us.
So thank you very much for listening to all the wonderful things that have been set up until now. They're very helpful, and that all kind of come together and intertwine. But as the studies are showing here, the number of long haulers with significant mental health symptoms is growing and substantial. And unpredictability, or as Bonnie said, and has Dr. Hebrew also indicated, the unknown is really, unpredictability or the unknown is the most difficult part of this. So I've told people since last spring that there's two pandemics going on. There's the normal pandemic, and then there's outside of COVID, the mental health pandemic. And I could take a long time just sharing with you all that I've seen as far as the grief, the anxiety, the depression that everyone has experienced, the isolation, the stress, not to mention the long haulers who've had some special challenges, as Bonnie outlined very well. But it's very clear with this mental health pandemic that's going on that it's gotten people's attention. And so people are starting to talk about mental health in a way that I have not heard them talk in the past. That's very encouraging for me to hear. And people are talking a little bit more freely about the mental health aspects of COVID in general, but also of the long haulers. And it's at least good to acknowledge the existence of depression and anxiety. And I really love seeing on both Dr. Lawler's slides and Dr. Hebrew's that they're including that mental health piece of it. Oxford did a study that 34% of people with the being diagnosed with it, long haulers, or even just with COVID, were ending up with a mental health disorder. That's just over a third of the people, and that for 13% of those people, it was the first time that they had a mental health diagnosis. I have told a lot of people that if someone had PTSD going into COVID, even if they were not a long hauler, their PTSD was worse during COVID. If they had anxiety or depression going into COVID, that during COVID, it got worse. So COVID kind of had that multiplying effect on everyone. So 17% of the people had anxiety, 14% of them were experiencing depression. And then, as some of you may have heard, substance misuse or even dependency increased. It says 7% of the patients, but as a society, in America at least, and probably globally, it has increased the use dramatically. And that insomnia is there as well. So some specific symptoms And the anxiety, the PTSD, as both doctors have indicated, if you're in the ICU for a period of time, then you're going to have PTSD just from that. But there's also fears, restlessness, a lot of irritability. I think that as professionals, as you all listen, as colleagues, as friends, family members, because many of us know somebody, and you'll hear a little bit about a family member of mine that contracted it, that really just taking it serious, taking all of these symptoms very serious, because the very first reaction that an actual COVID or long hauler patient has when they have these symptoms is, what is wrong with me? And our collective response has become, it's not just about how there's something wrong with you for experiencing this. This is a natural reaction to the unpredictable unknowns, like Bonnie said, the unknown surprises that are terrifying, and the experiences that they're very difficult. These symptoms are all very normal responses to what you're experiencing. So it's mostly that great uncertainty and fear. And I'll speak a little bit about some of the quotes from people from post-COVID or long haulers clinics. And so happy that they're being developed in Omaha as well. But the docs have said in their reports and their sharing with other people is, we don't have all the answers. We're just walking with them. We're just giving them hope, listening to them, validating, taking them very serious, because they're questioning themselves and they're questioning what's wrong with them, as I had said, and why are they developed these mental health symptoms. So listening to them, understanding them, validating really, really goes a long ways. I have a family member that had post-COVID that had COVID, was told that he had post-COVID pneumonia. And then one night when he showed up in the ER, was told that, no, you don't have post-COVID pneumonia. You're in the middle of, heart failure. You're in the middle of cardiac arrest. And if you had not come in today, you most likely would have died. And so they took him very serious. They gave him lots of hope. The docs, just the way that the docs listened and talked with him, were outstanding in my eyes. And I think that a little bit of therapeutic listening goes a long ways here, because it's so unknown and we can't give them promises, but we can give them hope. As Dr. Lawler says, with most people, the symptoms abate over time. So it helps them feel better, not only to move, like Dr. Hebrew said, but it also helps them to be listened to and taken seriously. So the message is, your pain is important and you're not the only one. It's a powerful message. That's the message I've given to people for my 36 years of practice, but especially long haulers need to hear this message, that your pain is important and it's universal. People around the world that are experiencing this are experiencing the same symptoms, are having what Bonnie talked about and illustrated so powerfully in her story. They're having anxiety attacks. They're having, a lot, just heartbreaking emotions, and hoping and praying, if they have that faith like Bonnie does, that it doesn't get worse. So, but they're also experiencing, many of them, a lot of shame and self-criticism. It's that, what's wrong with me that I'm experiencing this? Why can't I get through it like probably everybody else is doing better than me? But their symptoms are not made up. It's not in their head, but those are things that they might start telling themselves, unless if they're acute quickly. And if you tell them that other people are experiencing them, that's very powerful. But you're encouraging, as it was lovely to hear Dr. Hebrew talk about, Bonnie talk about, and Dr. Lawler, that mental health recovery goes hand in hand, hand in hand. So what you're doing, your message to them is this is normal, get the help you deserve. And ask them the questions. Are you experiencing some uneasiness with this? Are you experiencing depression? Is there some anxiety? Are you questioning yourself? And ask those questions at each visit, each follow-up. And that we all know as professionals that mental health recovery, if it's unaddressed, it'll impede, the physical recovery. If it's addressed, and if they're given tons of permission to be, normal and to have these emotions, then they'll have more hope. Oh, okay, it's not just me. I'm not failing. They'll think they're failing at COVID. So giving them a sense that they're not going about it alone is what one doctor said is half the battle, and encouraging their resources. And as Dr. Hebrew talked about. So here in the Atlantic Medical Group, one of the post-COVID clinics, they said, we're learning with them. We don't have all the answers. We're trying to give them hope because we're seeing some healing and some symptoms abating. So we're telling them that there is that possibility that some will, that you may be in this for quite a while, like Bonnie's describing, but that some parts of it can get better. But most importantly, that if you help them reach out to their resources and their support system and their therapist, that will increase their emotional strength in their patients. And we're providing hope, which is really rewarding. But he says we're taking people that are feeling lost with nowhere else to go and giving them a place to come to with this post-COVID clinic. And like we'll be experiencing in Omaha quite soon with Nebraska Medicine. So the support you're giving them is the support for the whole person. And here are support groups, resources, and I put in there the local therapist, and that's all in your resource packet. And I want you to kind of to look at that. But also, if you're somewhere else outside of outside of the country or outside of wherever, then I think make up your own resource sheet and give that to them, and give it to them every time. That's self-care. I love Bonnie's story because she talked about the healthcare workers and their hopelessness. And so we want the patient to take themselves seriously, and we want them to take their emotions seriously. That will help their healing. We want healthcare workers to see their self-care as serious. I have seen a lot of healthcare workers through the pandemic, and help them to take themselves very seriously, help them to give themselves breaks and to pace themselves, help them to not push and criticize for what has been is no longer, but what's the next step forward, and to reward themselves for that. To take stress reduction very serious in very simple ways. I've had lots of people talking about getting their hands in dirt and planting and how therapeutic that is for them, or just walking. And that relaxation and meditation does not have to be a professional experience. You don't have to be really good at. You really just stare at something that you love for a long period of time, whether it's a candle, a tree, nature, someone you love, then that's meditation. Acupressure, movement, yoga. Again, as Dr. Hebrew said, that movement really helps, but also it gives a person hope. I'm up, I'm moving. With my brother-in-law, he was in the ER when we drove to Tennessee to help my sister and him. And we passed the phone around as he talked to each person from the ER. And the next night, he was home. Because we were there, we had arrived. He wanted to be with his support system. You could tell he longed for that. And he just had to be able to walk so far down the hallway. And once we arrived to town, he had no problem doing what they said he needed to do to get home, because that's his strength. That's his emotional strength. And this is Bridget, who says that long COVID challenged her mental health. That fatigue is their most debilitating and consistent symptom. She can't walk short distances. My brother-in-law, I'm touching base with him frequently, and he is now just trying to walk the neighborhood and up hills. And he used to run. He's a high school basketball coach. You can imagine how physical he was before he got COVID. So the latter has felt quite shocking. My brother-in-law said, Maureen, I never, ever thought, and this is his truth and his battle, he is now being considered for a heart transplant. He said, I never thought I would be that person that's being considered for a heart transplant. So he's trying to wrap his mind around that new reality, just as Bridget is. And so it's had emotional challenges. She wondered if she was imagining symptoms. And was I responsible for being unwell for so long? Felt guilty for not being at work. And she outlines here her own mental health recovery. And I think that, see how simple she keeps it simple so it's not difficult for her. And that's the yoga. She's been with a long-term therapist over time. Music, artistic skills, coming together with others. I have people tell me every day in this room that just talking to somebody, talking it out is so therapeutic for them. Being taken serious when you're talking out. expressing themselves creatively, taking yourself into nature. Nature is been called the great equalizer. And except for one of my colleagues that has tremendous, problems with her, allergies, that's true for most people. So keep their body in movement, as Dr. Hebrew kept saying. And they learn, many people, and Bonnie has probably learned this or strengthened this, that you have to become very, very in tune to your body. But the coordinated care clinics are throughout the country, and Survivor Corps has a map for that. They also have support systems. And here's some of my resources. So thank you so much for listening today. Listen, take them serious, because they're struggling with the emotional piece as though they're doing something wrong, and help affirm them that they're not doing anything wrong. They're just being human. So thank you. And thank you, Sarah.
Thank you, Maureen. I think that, that advice goes a long way. The importance for all of us to remember of the value of really validating people's experience and normalizing that they're not the only one who's going through that is critical. And to give them permission to ask for help is critical too, because we live in a society where people don't want to ask for help. They don't want to show any signs of weakness, but to let them know that asking for help and being able to talk about this and process it is really an empowering thing that they can do to help themselves heal and to move forward. So thank you for your time with that. I do know we have about 7 minutes left, and we have had quite a few different questions that came in. And I just want to apologize. I know we won't be able to get to all of them in 7 minutes, but we will do our best to go through some of these that we have here. So one of the questions that came in, one of the first ones was for Dr. Lawler. And the question was, can COVID trigger the onset of diabetes? So if all of our panelists at this time, if you guys would like to show your videos and take yourself off mute, then our participants can watch. And then Dr. Lawler, again, the question was, can COVID trigger the onset of diabetes?
Thanks. So I'm not able to put my video back on, but hopefully you can hear me. Oh, there we go. Yeah, I don't know that there's been a lot of literature looking at new onset diabetes after COVID. I think it's certainly possible that people who might have what used to be called pre-diabetes or some impaired glucose tolerance may have, COVID push it over the edge, so to speak. I think that given what we've seen with this virus's ability to impact many different organ systems, it's certainly not out of the realm of possibility that you could get significant damage to the cells in the pancreas that produce insulin that could give you, new onset diabetes. But I think there's so much that we're still learning about this disease that we'll have to wait and see what we can find out when we start to evaluate, so many of these cases that we've accumulated.
Mm-hmm. Absolutely. Thank you. This next question actually really relates to you as well. And the question is, how soon after COVID can a person receive the vaccine?
So there's no perfect answer to that question, but right now I think most guidelines would tell you to wait a few months, and I think 3 months is a pretty standard answer for how long people should wait. And that's in part because we think that there is some protective immunity that comes from natural infection, and that immunity probably lasts several months. There's also some concern because people who receive a dose of the vaccine, and particularly so far what we've seen with the mRNA vaccines, because they are so immunogenic, if you receive a dose of the vaccine soon after having an active COVID infection, you have a more robust immune response and may experience more significant side effects than people who haven't recently had COVID. But 3 months is probably a good rough guidance for when to get the vaccine after recovering from COVID.
Thank you. Here's a question for Bonnie. Bonnie, this question is, how do you deal with COVID shaming, or when others do not believe how this has impacted your life long-term, or might feel as though you are just overreacting?
Unfortunately, I deal with that every day. I have friends, family members, not coworkers, but mostly friends and family that don't think it's real, or they think it might be real, but people are overreacting. And why do you want to get that shot? Because I got sick both times. I had symptoms, but they were greatly reduced from what I had before. And I would do it again in a heartbeat. I have a real hard time with those people discrediting me, not wanting to get the immunizations. But I'm trying to be mindful that, it's their right, and I have to do what's best for me.
Yeah. Very well stated, Bonnie. Thank you. I think we have time for one last question, because I do have a couple of quick announcements at the end of the presentation. So this is for Dr. Hebrew and for Maureen. What do you suggest that we do as community members to support each other in the current climate of the pandemic?
Go ahead, Dr. Hebrew.
Yeah, so just, as Maureen had mentioned, emotionally supporting, socially supporting one another. As Bonnie had mentioned, not encouraging a stigma. These signs and symptoms are real. They are just as real as any other systemic, illness that we're seeing in our typical patient caseload. And then, of course, encouraging healthy lifestyles. It's my big push as a physical therapist, encouraging exercise, really being good role models for yourselves and your peers and your social network, including your children. Big push for that from me.
Thanks, Caitlin. Anything to add, Maureen?
Just take it serious. Help people take it serious.
Okay, thank you. Kay, if you wouldn't mind sharing the screen, I just wanted to show you guys the resource packet quickly. You'll be receiving this in an email. You'll actually receive 2 emails from us at the conclusion of this event here momentarily. The first one will be a short evaluation, and we're asking you to please complete that. Let us know your feedback, things that you enjoyed and that you learned, if there's other information that you wish we would have included, any of those types of things. I've even had some people chiming in the chat box with specific comments for presenters. So those would be helpful things to include. We'll make sure that our different panel presenters got a chance to see that, all the comments as well. But this resource packet is several pages. It's a really convenient PDF format. If you wanted to scroll down there, Kay, just a little bit. We've tried to categorize for you a lot of different types of resources that are really helpful for the whole person, right? Not just physical health and mental health, but socially, spiritually, all these different things. So what we're hoping that you all will do is take time to review this and then share this. Pass it along to your coworkers, your family members, your healthcare providers, your neighbors, whoever it might be. COVID has impacted our entire world, and long COVID certainly is part of that equation now for many people as well. So we want people to feel understood. We want all of us to have the information we need to really be able to share that space with people and listen to them and try to connect them with different resources in the community that they may need. So we are very we're really happy actually to be able to put together this resource packet. We had volunteers on our committee who spent several hours across many days really putting this together. So we hope you find it useful. We also, I just wanted to point out real quickly, we'll be posting tomorrow on the Clarkson College YouTube channel the recording from this presentation, as well as the recording from the earlier one we did back on May 6th, which was geared more towards patients, family members, and community members in the general public. So we'll have both of these videos available. Again, we ask you to disseminate that amongst your contacts so people get the information they need and are able to really empathize with and support others. Any other final questions as we end this evening? Any other panelist comments? Okay, with that, thank you all for being here tonight. We appreciate your attentiveness and your participation, and we wish you the best. Take care.